So good day, everyone. It is, I know, bright and early where Midori is, and it's evening time here on the East Coast of the United States. My name is Audrey Snyder, and I'm one of the co-founders for the Global Rural Nurse Exchange Network. I practice as faculty at the University of North Carolina, Greensboro. And based upon your feedback, as Stacy said earlier, we were going to discuss a topic common, hopefully, to all areas, and that is hypertension or high blood pressure. So earlier with our other group today, our morning ambassador group, we had some really good sharing about how the challenges associated, what they see as the major barriers, and then also some ideas about what, as nurses, they might be able to do to make changes. So I thought I would just start by throwing out there, and I'm not asking for necessarily statistics, but how prevalent is hypertension in the population that you're working with, and what do you see as being some of the contributing causes in your culture?
I'll begin. Hypertension in my area is very prominent, and one of the leading chronic diseases that we have. I think a lot of the underlying factors is a lot of uninsured residents are not getting health care early, and they're presenting with higher blood pressure readings, diets, food insecurities, and education are big.
I would have to say in our area, it's very comparable. Diet, access to fresh, healthy food, and immobility because of long distances transportation-wise, a lot of sedentary driving, commuting long distances.
How about in your area, Midori?
Okay, I'm from in Okinawa, Japan. It's one is food, weight control. It's down too much. Alcohol and tobacco, smoking, and no exercise. Not enough exercise. Especially Japan, we have a lot of people eat pickles. I don't know what's called pickles. It's a lot of salty food, salty. I don't know what to say in the United States.
And how are people diagnosed and given the label as having hypertension in your areas? This morning, a lot of the group talked about the fact that it's not necessarily at screenings or prior. It's not until someone may have a significant event like a stroke or a heart attack and they're in the hospital, and then they have the diagnosis.
I would have to say in our area, it is more reactive than proactive, and there isn't, not that there's not an, we have stroke prevention clinics, we have information messaging, it's discussed at every health clinic, it's all over the media, but I don't know that there's an actual, the level of seriousness is taken around the preventative, proactive side of it. The information is there, it's the engagement in addressing the risks that could be presented for people based on their own situation, whether there's family history, there's obesity, they're diabetic, they're smokers, or those kinds of things. It's not that it's dismissed here, the information is well disseminated. It's an acceptable risk almost in society here, if you want to call it that.
It's an interesting perspective. I know in speaking with some of our other ambassadors, they felt that one of the challenges was, which wouldn't be the case in Canada, I don't think, that non-communicable diseases like hypertension and diabetes are kind of ignored by the government, that communicable diseases like HIV/AIDS have money put toward them, and those persons can get all of their medications for free and their visits to a physician for free. Whereas if you have hypertension, even if you've had a stroke and you've been diagnosed and you're sent home, that coming back into a clinic to get care and to fill prescriptions requires money, which many of their residents would not have. So even if they're diagnosed, there's not a way to deal with that aspect of it. And so we talked a lot about patient education for prevention, but also patient education regarding lifestyle modification, and looking at ways that maybe they could change following something as significant as a stroke with someone who has hypertension. What are your thoughts, Trish? I'll put you on the spot.
I agree. It's a lot of reactiveness here also. Plus, we're in the South, the tobacco belt. So like she said, there's smoking, there's a lot of salt in our cooking. So I think all of those things are, and it's usually when something has happened is when they want to address the issue. We get them coming in our clinic all the time. I feel fine. And, you know, the old adage is you're going to feel fine until you're not feeling fine. And they have a 200 over 120 blood pressure. So education is out there. The warnings, stroke warnings, what's out there is just, it's just with so many that lack access to care. So they don't really realize that they're having blood pressure issues and they're needing to be taken care of because they haven't had a situation happen yet, haven't been in the hospital and been diagnosed, or to a doctor and been diagnosed.
Trish, could you speak a little bit to the challenges I think you have where you're at as far as the Hispanic population?
So with the Hispanic population that we have, it's harder to reach, especially the men. There are a lot of farm workers, agricultural, landscaping, and they work from sun up to sundown. So getting them in to have screenings or getting them into doctor's visits is a big obstacle. Also, the language barrier. I think we have a lot of things in place for the language barrier. We have interpreters and interpreter lines and things like that. It's just reaching them. And then also culturally, the things that they use in their diet, and then also incorporating our diets into their diets has kind of produced a lot more salt intake, less vegetables, those kinds of things. The women are usually they're usually really wanting to take care of their health, but it's usually when it's a crisis situation. And it's also still the same barriers. You're usually at home taking care of the children, so they're not as readily able to get out to visits to their doctors. It's a crisis. Affordability, and of course, if they are undocumented Hispanics, then they're not eligible for some of the insurance aid. But they just don't want the bills, and so they won't go for care. It's kind of a two-edged sword, but they do. They're really welcome that. I'm sorry, my internet's going in and out with the storm, so I don't know what you're hearing and what you're not hearing.
We were able to
We
hear you.
have more
It's a little
diabetes.
fuzzy.
I mean, I think hypertension, more diabetics in that population than we have with.
I think we did lose her now. Midori, would you have anything to add to the conversation about your area?
It's kind of similar. It's stroke and diabetes, cerebrovascular disease. Also in Japan, in a law, we have to have a check once in a year, health check. That is must. So it's like in a small island, about 300 people, 400, however, people have to health check. So that health check, in the 140 and 90, it's diabetes, hypertension is average. However, people doesn't want to go take care of medicine. You know, a lot of people don't want to take medicine because, no symptom.
Right.
Yeah, that is a big problem.
And many times hypertension is called the silent killer
Yeah,
because
right.
they feel well. It's like, why do I take a pill if I feel great? And then there are times when people can't, for whatever reason, maybe, excuse me, they can't afford their prescriptions, or they may have distrust with taking pharmaceuticals. And I will ask, in your areas, are there specific things that some of your clients may do besides lifestyle modifications for treatment of hypertension? That's not pharmaceutical, not lifestyle changes. Are there herbs that they may use to treat hypertension? Self-treat, I should say.
Vinegar is a big one here. There are a lot of patients that will just take vinegar instead of taking their blood pressure medications.
I know one of the research studies that I worked with some students in doing in Appalachia, and this was trying to look at, we were bringing in episodic clinics to provide care, and we screened a lot of people and diagnosed them with hypertension. And when we asked patients about, well, would you rather see a doctor versus not? And, the response is, yes, I'd like to see a physician, but if I don't have a physician available to see, which is a big problem in Appalachia, then we rely on what's handed down by generations. And so for almost everything, they would use a combination of predominantly 4 things: honey, lemon, vinegar, and whiskey. And so it may be just one of those items or a combination of those items, depending upon what the problem is. But I even found Appalachian cookbooks that had little recipes in it for treating different things that included those 4 ingredients. So we do see many times that if patients are anti-pharmaceutical or can't access or can't afford, they may look to other things. In some island nations, when they may not have good access to pharmaceuticals or may not believe in using pharmaceuticals, they may go to nature and find certain plants, and they just refer to it as bush tea because they take the plant leaves and they seep them into a tea that they drink. So I don't know if there's anything like that in your area that people may do. Trisha has already talked about vinegar in our area, that people will drink vinegar to treat their hypertension. Midori or Charlene, do you have anything that's more of what we would think of as folk remedies, or something that's culturally ingrained that people may do that's handed down by generations?
I think in the past, with our First Nations historical communities, there was the current, not so much. We're not seeing that in this generation of First Nations people here. the tendency is to go, move towards the more modern medical approach, and which is reactive.
So once something has happened, like a stroke or a heart attack, then receive treatment.
There are small, tiny pockets of still some traditional, as there are in some rural cultures like the Hutterite colonies, the Mennonite, and so forth. But the reality is that that traditional approach over the generations has, for the most part, been lost. They're very few and far between. But and going back to the earlier statement, I think it's not that information isn't out there. It is out there. I sometimes wonder if the messaging or the context of it is not probably being messaged well enough. We have in Canada quite a high, our cultures are we're quite a mixed population. So even in my work, day-to-day work, we come across a lot of variations in languages. And so we work often with the systems that will provide translation. We've also looked at alternative documents with alternative languages. And we always go to our ministry, our government, provincial government, to see what the most common top 10 are each year. And we update documents online electronically and in written format based on that annual, or every couple of years it changes, sometimes less often, but more recently we've seen more change. But the reality is that the messaging can't be disseminated to every culture and every venue and every community. So the general informational, educational messaging is out there, but it still boils down to individual choice and the decisions individuals are making at a social level, in society. When I say social, I mean society. So that becomes, the cultural norm. If you have a community that is adamant about their local sports, they in a rural or remote community, they tend to jump on board if it's a high, really focused hockey community or focused baseball, softball community, people get on board. I think we see the same thing with health. If the community isn't engaged in something, then it isn't, the uptake isn't there. So this being one of them, I think we could do a better job of maybe working on the societal, cultural piece, because they know what their community's unique way of buying into things is, right? So for example, in one of the departments that I worked, one of the northern communities, to get buy-in with individuals taking TB medication, they often were engaged in clinics if we brought in a draw item, like a flat screen TV, and they could throw their name in for a draw. Then we would get high numbers of engagement. If we offered a $20 incentive to take the medication, they would come in droves. So there seems different communities are receptive to different things, depending on, where the risk level lies, what engagement the government is willing to, expend to financially. So it's tricky.
It reminds me of the community-based, like participatory research. I think that anytime you're doing something that may be seen as maybe novel or different to that community, getting the buy-in of the people who are in the community to say what might work, like you're talking about, whether it's with TVs or drawing or money, may be helpful.
It's understanding the community. I think getting to a level where you understand the community and what engages them. And that's inconsistent. And it also is variable amongst cultures. We're communicating and trying to understand that. So there's a huge element of research. You know, I know and some people feel like they've been researched, they say, to death because they've been asked a million questions and nothing happens. We hear that all the time, right? I think there may be maybe a different approach other than research. We do, when I suggest, you know, gave those two examples, those are examples that were effective, that worked. We would have never, you know, anticipated the success that we had, but we did, and it worked. So then you run with what works in a specific community. When it comes to health and engagement and being on the upstream proactive side, right?
Yes.
Yes, it's different in every country, but and I can only speak for one element, but that would be an example where we could probably do a little bit more digging.
Yeah. I know in Appalachia, it was really hard to get people to see the physician, but we started screening every patient who was seeing the dentist at these episodic clinics. And if their blood pressure was high or their glucose was high, there was a cutoff where the physicians would work, the dentist would work on them. So then they had to see a physician to try and get management of their diabetes and their hypertension before the dentist would touch them. And all the care was free. It wasn't a matter of cost. All the care was being provided free of charge. But it took that desire to have their teeth fixed to get them to see a medical provider about the medical problems. So it's interesting. Midori, do you have any experiences in Japan that are similar or different, or that might flow along with the conversation of trying to understand the community and be creative in how you provide resources?
I don't have much knowledge, but I heard about it's a small island. We have a lot of small island, you know, it's a small island living, it's like aging population for old people. It's believe shaman. We are very famous. It's kind of, we call Utami, and shaman is especially old people believe in the shaman, and they cut in what do you say in cut a skin and then take out blood, meaning bad blood. Bad blood, you know, it's knife and the cut of take out blood and not much. So they believe, you know, it's some kind of ritual thing. Also, you know, a roots, it's some kind of roots, and they drink.
So would you say that the cutting is more like bloodletting, like similar to what happened in the Middle Ages?
Right, but just it's not heavy cut, just it's called, you know,
Scarring.
yes, take out bad blood. That doesn't work, I know that. Yeah. Also, it works in, I heard it works in a nursery, you know, a small village in several points. We put a blood pressure thing. So it's people just go anytime and nobody steal that. So getting better. So anytime people wanna take in the blood pressure, anytime they can. So it's stroke, it's decrease. That was very interesting. Yeah, you don't have to go clinic, but self-check, not in a home, self-check in a, some community basis.
Mm.
They talk and they take blood pressure anytime. So it's kind of free, no cost.
Yes.
Or they control themselves. It works.
I know. And here you can go into most pharmacies and they have a blood pressure machine that you can get your blood pressure taken without there being a cost. So that does allow for some self-control, some self-evaluation and monitoring.
Well, it's a small island. We don't have no pharmacy. Only like one doctor and one nurse. So they only open 9 to 5 o'clock. Then Saturday, Sunday is off. So no pharmacy in small islands. So that is, they have to have a self-control in your blood pressure.
Are there specific like government recommended pharmaceutical protocols for treatment in your area? This morning, some of the groups talked about, the use of diuretics potentially initially converting to ACE inhibitors. Some even had a 5-step process, but it was government regulated. You do this level. If that doesn't work, then you do go up to step 2. And if that doesn't work, you go to step 3. But again, it's whether or not people are receptive, if they will adhere to the guidance that's been given. There was a lot of focus in some of our other conversations about the patient education piece and really trying to get the lifestyle changes embedded. And in many rural communities, people are working. And so, yes, they may have a physically laboring job. So that might use certain muscles in a certain way. But then when they're off work, maybe distance traveled to their work or just long days, they don't want to do exercise because that again is something else that they're tired already from their job. So that could be a factor where that they may not want to engage in those lifestyle modifications. We've recently worked with some women, minority women, on cardiovascular health. And we did a combination of health screenings, health education, cooking classes, and nutrition information. And with this group of women, the outcomes showed that what helped them the most was the factual nutrition information, that they didn't really have that background and that understanding of the foods that they were eating and what that meant to their body. And I know there's been a big push now, at least in some parts of the US, of the idea of food as medicine. And so if we can really focus on what foods are healthy and help people to make better choices. And many times it's not just the choice, but it's food access and access to healthy foods that can make a real difference for people. Are there other aspects of hypertension assessment treatment that you all would like to share from your prospective regions or areas?
Recently in Japan, we gave a lot of information, sleep hygiene.
Yes, sleep hygiene.
Yes, people didn't pay attention a long time ago, but that's caused a problem for diabetes and hypertension. So it's a lot of TV and focus on sleep hygiene. Yeah.
And even just the concept of, how much is salt used in a diet or in an environment? In many of the Caribbean islands, historically, they didn't have refrigeration. So food was preserved using salt. And even in the rural area that I grew up in, salt was a part of canning beans, for example. But I know, having just been in the Caribbean, and every time I walked in the store, grocery store that is, there was saltfish there. So using salt as a preservation method. And then, well, how do we teach people if this is ingrained in their culture and this is something that they're going to do to preserve their food? But to work with them on how they soak the fish to kind of reconstitute the dried fish, and changing the water frequently to decrease the amount of salt that's still present with it as they prepare foods. Many times they use this in stews with other vegetables, and so then to not add any additional salt. Earlier today, one of our ambassadors talked about recommending, if people did use salt, to use Himalayan salt because it has a lower sodium content in it. Are there any other culturally specific things in your areas that you find yourself talking to patients about or recommending?
We have the same problem. It's especially also in Japan. They eat a lot of salty pickles because deserved in wintertime a lot of snow. So they use they make a lot of pickles with salt, like vegetable, especially vegetable. So they only eat in the pickles and rice, white rice. So their stroke was very high. But however, public health mask in starting and it's don't take in salt, how to use lemon and some different kind. So it's education was very works good. So that community it's much better not taking salty food. It was takes time.
Yes.
Yes. Yeah.
And as some people spoke today of using ginger or onion to flavor with, or herbs that might flavor foods to try and get away from the salt that people may be wanting to use.
Especially in the public health nursing recommended, we call it noodle. You can eat noodle, but don't drink in the soup. Soup is porky. That is works also, A lot of people in Japan, they love noodle. It's cup noodle.
Yes.
Don't drink soup. Just eat noodle.
Okay.
Yes.
So we've covered a lot of ground this evening or morning, depending on where you're at, in talking about hypertension and the common challenges that we have, which span across nations, and some of the risk factors. And I think many times a lot of the things are potentially modifiable risk factors. We know genetics plays a role for some people. Ethnicity may play a role, and just culturally, things that are ingrained in a culture that are handed down from one generation to another generation. So I'm hoping that you all got some ideas from each other on some things that you might be able to consider in assessing for, or even, the idea that Charlene said of acceptable risk. And I don't think I've heard that terminology being used before in relation to hypertension, but acceptable risk. So what are people willing to take as a risk versus being diagnosed or being treated for it? So I'm going to do a little lit review and see if I find that in some other areas. Trish, have you had that in your work?
Not that terminology. No, I'm gonna also look that up and see if it's mentioned. But yes, it sounds plausible here. I mean, people are willing to. They don't want to give up what they're used to and what's ingrained in them from childhood. They would rather take the risk of, well, I feel okay now. So, I'll address that issue if something happens.
And just the lack of engagement. I'm sorry.
Well, that's okay. I was just saying we've had good success with a remote monitoring program that we started here at our clinic. our LPNs, the health coach,
Uh-huh.
and we've identified a pilot group, and they get a Bluetooth capable blood pressure and a weight scale. And so they weigh every morning and every evening, and we can see a dashboard with their numbers on them and report those to the provider if we need to see something that's trending that needs to be addressed. But just address those lifestyle changes. Stress management is a big key. Medication, how to take your medicine, when to take your medicine, and that you really need to keep taking your medication and to get it filled frequently and have your follow-up visits. But it's really been a key. It has helped a lot of our patients, and we've seen some excellent changes in people's behavioral modifications and getting them out exercising and lowering their stress levels and doing their follow-up visits.
That's great. That is utilizing technology to help. I know that empowerment for some cultures seems to be a big challenge, that clients don't feel empowered to make changes in their health or to take control of what's happening. So sometimes being able to provide that coaching is definitely a positive aspect and is needed to try and help people feel in control of their own health and feel like they can make some lifestyle changes, even if it's little changes at a time, but to slowly try and improve the health conditions that they may have. Well, we're winding down on time now. Are there any closing thoughts from anyone? Anything we didn't talk about that you were hoping we would talk about today? Or anything that you'd like to add now? Well, I will turn it back to Stacy after thanking you all for participating and being here. And I look forward to our next conversation with the ambassadors, and hope that this has been a productive session for you all to share ideas, and we'll get all of this loaded, or Stacy will get all of this loaded.